Thank you for joining us for this deep dive into the anesthesia management for one of vascular surgery's most critical procedures, carotid endarterectomy. All right, here's our game plan for today. We're going to take a really comprehensive journey through the perioperative management of carotid endarterectomy, or CEA. We'll build your knowledge from the ground up, starting with the fundamental principles, then we'll walk through a real-world patient case to see it all in action. After that, we'll dive really deep into the clinical decision-making around anesthetic choice, advanced monitoring, and the postoperative care that really defines this high-stakes procedure. So let's get started. So let's start with the absolute fundamentals. Before we can even talk about how to manage the anesthetic, we need to have a rock-solid understanding of why we even do this procedure, who these patients are, and the unique physiological challenges this surgery throws at us. The whole point of a CEA is incredibly important, and the evidence for it is just crystal clear. For a patient who's had symptoms and has a severe stenosis, this procedure takes their 2-year stroke risk from a terrifying 1 in 4 chance all the way down to less than 1 in 10. The famous NASCET trial gave us that level 1 evidence, and really, our entire perioperative mission is to protect this incredible benefit by getting the patient safely through the procedure. The root of the problem, the villain in this story, is atherosclerosis. It's that plaque buildup that loves to happen right where the common carotid artery splits into the internal and external branches. Now, this plaque is dangerous in 2 main ways. 1, it can get so big that it physically chokes off blood flow, creating a low flow state. Or, and this is actually more common, it can get unstable, crumbly, and break off little pieces that then travel up into the brain and cause an embolic stroke. And this image just illustrates it perfectly. This is what we're up against. You can see that critical narrowing, that choke point for blood flow heading to the brain. This is the exact lesion we need to fix. And of course, protecting the brain while this very artery is clamped is the central challenge of the entire anesthetic. Our patients for this surgery are almost never simple. They are a complex constellation of comorbidities because atherosclerosis is a systemic disease. If they have plaque in their carotids, you can bet they have it in their coronaries. Hypertension, which we see in about 2/3 of these patients, chronically shifts their cerebral autoregulation curve to the right. What that means is their brain is way less able to protect itself from swings in blood pressure, which makes our job even more critical. Then you add in coronary artery disease and diabetes-induced autonomic dysfunction, and you've got a patient who is just primed for myocardial ischemia and profound hemodynamic instability. So this brings us to a crucial point, maybe the most important one for your daily practice. Your primary task is dynamic, phased blood pressure management. It's not one target, it's 3. Before the clamp goes on, you often need a slightly higher pressure to push blood through that tight stenosis. Then, during clamping, you might need to augment pressure even further to drive collateral flow from the opposite side through the circle of Willis. But the second that clamp comes off and flow is restored, the game changes completely. You have to aggressively avoid hypertension to protect that fresh suture line and prevent the absolutely devastating cerebral hyperperfusion syndrome. And let me tell you, your vigilance does not end in the operating room. In fact, it really intensifies. Hemodynamic instability is the rule, not the exception, because surgery on the carotid sinus just messes with the body's baroreceptors. A wound hematoma in the neck isn't just a bruise. It is a rapidly expanding surgical emergency that can take an airway in minutes. And cerebral hyperperfusion syndrome, while rare, is a true nightmare scenario with a mortality rate over 50% if it's not recognized and treated immediately. Okay, so with that foundation in place, let's walk through a clinical scenario to see how all these principles actually apply in the real world. This is where we turn theory into practice. Let me introduce you to Mr. Church. He's a 68-year-old who shows up in the emergency department after an episode of right-sided weakness and difficulty speaking that thankfully resolved within about an hour. His TIA is a critical warning sign. It's basically a stroke that almost happened, and it triggers a very urgent workup. The diagnosis is confirmed with this angiogram, which shows a severe, high-grade stenosis of his left internal carotid artery. Now, we know from the evidence that the risk of a major permanent stroke is highest in the first 48 hours right after a TIA. This knowledge creates a real sense of urgency, pushing the team to push for early surgical intervention. So the anesthesia team gets together and discusses the options, and this is really the central debate in CEA anesthesia. We're going to do a much deeper dive on this later, but for Mr. Church, the key trade-off is this. General anesthesia gives you a secure, controlled airway and a perfectly still patient. Regional anesthesia, on the other hand, lets you have continuous real-time neurologic monitoring with an awake patient, which remains the undisputed gold standard for detecting cerebral ischemia. The team decides to proceed with regional anesthesia. In the OR, the surgery goes beautifully. The artery is exposed, it's clamped, the plaque is meticulously removed, and the vessel is closed. Mr. Church stays awake, he's calm, and he's neurologically intact the entire time. But upon arrival in the recovery room, a brand new challenge pops up. Mr. Church starts developing this severe pounding headache on the same side as his surgery, and his blood pressure spikes to 190/100. These are the classic, really ominous signs of cerebral hyperperfusion syndrome. Just think about it for a second. The blood vessels in his brain downstream of that stenosis have been seeing low pressure for years. All of a sudden, they're exposed to normal or even high pressure, and they've completely lost their ability to constrict. They just dilate passively, leading to leakage, brain swelling, and the risk of a catastrophic hemorrhage. Now, what's so great about this is that there's a clear, stepped protocol for this emergency. There is absolutely no time to waste. The team immediately kicks into gear with aggressive blood pressure control. First line is IV labetalol in careful, titrated boluses. If that's not cutting it, they move to hydralazine, and then if needed, a GTN infusion. The goal is singular and urgent. Get that blood pressure down, keep it tightly controlled, and reverse this process before it progresses to a bleed in the brain. Thanks to this quick, protocol-driven action, Mr. Church's symptoms resolve, and he makes a full recovery. His case just powerfully reinforces our core principles. First, blood pressure control isn't just one part of the job, it is everything. Second, the value of awake monitoring is undeniable. And third, our job isn't over when the patient is extubated. Constant postoperative vigilance is absolutely critical. That case really highlights the critical choice we have to make between general and regional anesthesia. So now, let's take a much deeper, evidence-based dive into the pros and cons of each approach. Okay, this table pulls together data from a bunch of studies, including the very large GALA trial. Now, the GALA trial famously showed no major difference in the big primary outcomes like 30-day mortality, stroke, or MI. So bottom line, you can do this safely either way. But when you look closer, you see these nuanced differences that should really guide your choice. With GA, you get that secure airway and a totally still patient, but you give up your best neurologic monitor. With regional, you keep that monitor online, but you have to manage patient anxiety and always be ready to convert to general if you have to. And notice the difference in shunt use. It's higher with GA, probably because you have to assume ischemia when your monitors change, whereas with regional, you only shunt if the patient tells you they're having symptoms. Okay, this is a huge takeaway. If you're going to take a mental snapshot of one slide, this might be it. You have to remember this inverse hemodynamic relationship. With GA, your main headaches are fighting hypotension on induction and then bracing for a hypertensive surge on emergence. With regional, you're often treating hypertension during the surgical stress of clamping, followed by a tendency towards hypotension after reperfusion as those baroreceptors reset. Understanding this pattern lets you be proactive, to have the right drugs drawn up and ready instead of just being reactive. All right, so let's say you've opted for general anesthesia. You've lost your best monitor, the awake patient. Now what? How do you see what the brain is doing? Let's go over the advanced tools we can use to protect the brain when the patient can't protect themselves. Carotid stump pressure is the classic, old-school technique. The surgeon clamps the carotid and literally hooks up a pressure transducer to measure the back pressure coming from the other side via the circle of Willis. It gives you one number, a single snapshot of collateral flow. But honestly, its utility is highly controversial. There are no universally accepted threshold values, and it doesn't always correlate well with outcomes, so most people consider it just one data point among many. The EEG is one of the most common and valuable monitors we have under GA. It's our real-time electrical map of the cortex, giving us continuous data on brain function. What you're looking for is a significant change on one side after the clamp is applied, a loss of frequency or amplitude on the surgical side. This is a pretty strong indicator of ischemia, and a clear trigger for you to do something, either by asking the surgeon to place a shunt or by actively increasing the blood pressure. And this right here is probably the single most important clinical pearl for anyone using EEG during these cases. You must maintain a steady anesthetic state. If the patient's blood pressure goes up and your first instinct is to treat it by cranking up your volatile agent, you will suppress the EEG. This can look exactly like cerebral ischemia, rendering your monitor completely useless and maybe even leading to an unnecessary intervention. Hemodynamics have to be managed with vasoactive drugs, not by changing your anesthetic depth. Now, for a really fascinating tool, transcranial Doppler, or TCD. It uses ultrasound to measure the blood flow velocity in the middle cerebral artery, giving you continuous feedback on perfusion. A big drop in velocity after clamping is an obvious sign of hypoperfusion, but its most unique and powerful ability is to detect microemboli. They show up as these characteristic high-intensity signals like little chirps on the audio output. In a way, TCD lets you hear the enemy, and a high number of these embolic signals has been linked with postoperative stroke. And finally, there's cerebral oximetry, or NIRS. The easiest way to think of this is as a pulse oximeter for the brain. It uses near-infrared light to measure regional oxygen saturation in the frontal cortex. The key here is to watch for a significant drop from the patient's own baseline after clamping. However, the absolute values vary so widely between people, and its overall sensitivity and specificity are pretty low. It's a useful piece of the puzzle for sure, but it should never be used as the sole determinant of cerebral perfusion. Okay, let's transition into the final phases of care. We'll focus on that really critical postoperative period and also touch on the main alternative to open surgery. Just like we saw with Mr. Church, the postoperative period demands intensive monitoring, ideally in a PACU, a high-dependency unit, or an ICU. You should absolutely expect hemodynamic instability and have IV vasoactive drugs ready to go for the first several hours. This is also the time to be hypervigilant for any subtle neurologic changes, any sign of neck swelling that could signal a hematoma, and of course the ever-present risk of myocardial infarction, which remains a leading cause of long-term mortality in this patient population. But what about for some patients, particularly those at a really high surgical risk? Maybe they've had previous neck radiation or a prior radical neck dissection, or what surgeons call a hostile neck. Well, for them, an endovascular approach is a valuable alternative. This is carotid artery stenting, or CAS. And this illustrates the result of CAS just brilliantly. On the left, you see that severe stenosis. On the right, you see the wide-open lumen after a stent has been put in place. A wire is passed through the stenosis, usually from the femoral artery, and the stent is deployed to essentially scaffold the artery open from the inside, completely avoiding a neck incision. Now, what's really interesting here is that CAS has a completely different, almost opposite hemodynamic profile from open CEA. With CAS, the primary concern is profound bradycardia and hypotension. This is caused by direct, intense stimulation of the carotid sinus baroreceptors as the balloon is inflated and the stent is deployed. You absolutely have to be prepared with atropine and vasopressors like phenylephrine. And just like with regional CEA, these procedures are almost always done under light sedation, so you can keep your best monitor, the awake patient, online. Phew! Okay, we have covered a huge amount of material. So let's take a minute and distill it all down to the most critical, actionable principles you can take with you into your clinical practice. Okay, takeaway number 1. If you remember absolutely nothing else from this explainer, please remember this. Your single most critical task is meticulous, phase-specific blood pressure management. Your target changes before, during, and after clamping. Getting this right protects the brain from both ischemia and hyperperfusion, and it protects the heart from ischemic events. It is the absolute core of the anesthetic. Takeaway number 2. While all of our advanced monitors under general anesthesia are valuable and they're getting better all the time, nothing has yet replaced the sensitivity and specificity of an awake, cooperative patient who can simply tell you when they're developing symptoms. This is just a fundamental truth of carotid anesthesia. And finally, takeaway number 3. Your role extends far beyond the OR doors. From recognizing a neck hematoma that could compromise an airway in minutes to initiating the emergency protocol for hyperperfusion syndrome, the postoperative period is just fraught with risk. A high index of suspicion and a low threshold for intervention are absolutely essential to preserving the benefit of this procedure for your patient. And so we'll leave you with this final thought to chew on. The landscape of this procedure is changing. The evidence is pushing us towards more urgent surgery on sicker, more complex patients. And this challenges all of us to continually refine our anesthesia strategies, to master our monitoring techniques, and to perfect our team-based approach to protect our patients during this critical, brain-saving intervention. Thank you so much for joining us.